Hello there. Are you over the age of 65 and feeling confused about whether you should still be taking a daily aspirin to prevent a heart attack? If so, you are certainly not alone. For decades, the advice was simple, almost a mantra in medicine for older adults. Take a baby aspirin a day to keep the heart doctor away. It was seen as a safe, inexpensive insurance policy against one of our greatest fears, a sudden, catastrophic heart attack or stroke. But in the last few years, the ground has shifted beneath our feet. New guidelines have emerged and headlines have followed, leaving millions of seniors and, frankly, even some doctors feeling uncertain about what is truly the right thing to do. One day, it's a life-saving wonder drug. The next, it's a potential danger. It's enough to give anyone whiplash. My name is Dr. Robert Clark, and for over 30 years my work has been dedicated to the health and wellness of seniors. I've sat with thousands of patients, just like you, navigating these very questions. Today, my goal is to clear up this confusion once and for all. We're going to cut through the noise and look at the clear, evidence-based science. We will talk about what has changed, why it has changed, and most importantly, what it means for you and your health going forward. This isn't just about a pill, it's about understanding your personal health journey and making informed, confident decisions with your doctor. I want to empower you with the knowledge to have that conversation. So, grab a cup of tea and let's talk. Let me tell you about a patient of mine. Let's call him George. George is 72, a retired postal worker who walks 2 miles every single morning. He's never had a heart attack, never had a stroke, and his blood pressure is well controlled with a single, low-dose medication. For the past 15 years, on the advice of his previous doctor, he has dutifully taken an 81 milligram aspirin every day. When he came to see me last month, he brought in a news article his daughter had sent him. The headline was something alarming like, "Aspirin may do more harm than good for healthy seniors." George was visibly distressed. "Doc," he said, "I've been doing this for 15 years, thinking I was protecting myself. Have I been hurting myself this whole time?" George's question is the exact reason we're having this conversation today. It's a question born out of a desire to do the right thing, complicated by changing medical knowledge. The anxiety he felt is real, and it's shared by millions. The good news is that we now have much clearer answers than we did even a few years ago. The story of aspirin is a perfect example of how medicine evolves. We gather more data, we conduct larger and better studies, and we refine our recommendations. What was once a blanket recommendation has now become a very personalized decision. And this is a good thing. It means we are getting smarter about not only preventing disease, but also about preventing harm from the very treatments we prescribe. So, have you ever felt like George, caught between old advice and new warnings? Do you worry if the medications you've trusted for years are still the right choice for you today? To truly understand why the advice on aspirin has changed so dramatically, we need to look at the landmark shift in the official medical guidelines. For many years, the prevailing wisdom was that since aspirin thins the blood by making platelets less sticky, it could help prevent the formation of blood clots that cause heart attacks and strokes. The logic was sound, and for certain patients it proved to be incredibly effective. This led to a widespread recommendation that older adults consider taking a daily low-dose aspirin, even if they had no history of heart problems. This approach is what we in the medical field call primary prevention. Think of it this way. Primary prevention is about preventing a first major event. You've never had a heart attack, never had a stroke, you haven't had a stent placed in your heart arteries or undergone bypass surgery. You are trying to prevent that first fire from ever starting. For decades, we believed aspirin was a key tool in that initial fire prevention plan for a broad population of older adults. Then, in 2022, the U.S. Preventive Services Task Force, or USPSTF, a highly respected, independent panel of national experts in disease prevention, issued a groundbreaking new recommendation. They concluded that for adults aged 60 and older, starting a daily aspirin for the primary prevention of a first heart attack or stroke was no longer recommended. This was not a minor tweak, it was a complete reversal of long-standing advice. So, what prompted such a major change? The primary driver was a wealth of new evidence, most notably from a massive and meticulously conducted study called the Aspirin trial. Aspirin stands for Aspirin in Reducing Events in the Elderly, and it was one of the largest studies of its kind ever conducted. It involved over 19,000 older adults in the U.S. and Australia, with a median age of 74, who had no prior cardiovascular disease. These were healthy seniors, much like my patient George. The study participants were randomly assigned to take either 100 milligrams of aspirin or a placebo every day, and they were followed for an average of nearly 5 years. The medical community was waiting for the results with bated breath. We all wanted to know, definitively, does a daily aspirin help a healthy older person live a longer, healthier life? The results, published in the New England Journal of Medicine, were stunning. The study found that for these healthy seniors, taking a daily aspirin showed no statistically significant benefit in preventing a first heart attack or stroke. The rates of cardiovascular events were almost identical between the group taking aspirin and the group taking the placebo. But that wasn't the whole story. The study also revealed a significant downside. The group taking aspirin had a substantially higher risk of major bleeding. This was the critical piece of the puzzle that tipped the scales. The fundamental promise of a primary prevention medication is that its benefits must clearly and decisively outweigh its risks. The Aspirin trial, along with other corroborating studies, showed us that for the general population of healthy adults over 60, that was simply no longer the case for aspirin. The potential for harm, specifically from bleeding, had become too great to ignore, especially when the expected benefit had all but vanished. This is why the guidelines changed, and it represents a crucial step forward in making medical advice more precise and safer for seniors. Have you ever heard of the terms primary and secondary prevention before? Does this distinction help you understand where you might fit into these guidelines? With this new understanding, let's be very specific about who should not be taking a daily aspirin for heart health. According to the current guidelines, if you are an adult aged 60 or older and you have no history of heart attack, stroke stents in your heart arteries, or bypass surgery, you should not start taking aspirin to prevent these conditions. I want to be crystal clear on this point. The evidence we have now, primarily from that large Aspirin trial, tells us that for this group of people, the risks of daily aspirin use outweigh the potential benefits. Let's dig into those risks a little deeper, because understanding them is key to appreciating why this change was made. The Aspirin trial found that seniors taking aspirin had a nearly 40% increased risk of a major hemorrhage, or serious bleeding event, compared to those taking a placebo. What does a major bleeding event actually mean for a person's life? It's not just a minor cut that takes longer to stop bleeding. We are talking about two main types of serious bleeding that can be life-altering or even life-threatening. The first is gastrointestinal, or GI, bleeding. This can manifest as a bleeding ulcer in the stomach or intestines. It might present as vomiting blood or having black, tarry stools. A significant GI bleed often requires emergency medical attention, hospitalization, blood transfusions, and invasive procedures like an endoscopy to find and stop the source of the bleeding. For an older adult, this is a major medical crisis that can lead to a long and difficult recovery. The second, and perhaps more frightening risk is intracranial hemorrhage, which means bleeding inside the skull. This is a type of stroke, a hemorrhagic stroke. This can cause permanent brain damage, leading to paralysis, speech problems, and profound disability. The Aspirin trial showed a significant increase in this type of devastating event for the aspirin group. Let me tell you about a patient of mine, Eleanor. She's 78, an avid gardener and book club president. Like George, she was taking a daily aspirin just in case. She had no history of heart disease. One afternoon, she felt suddenly dizzy and weak. She was brought to the hospital and diagnosed with a severe bleeding ulcer. She required 3 units of blood and an urgent procedure. Her recovery was slow, and it took her months to regain her strength and get back to her garden. Her doctor in the hospital, and I later on, concluded that the daily aspirin was the most likely culprit. This is a real-world consequence. For Eleanor, the insurance policy she thought she had against a heart attack ended up causing a completely different but equally serious medical emergency. The reason this happens is that the very mechanism that makes aspirin work against blood clots, making platelets less sticky, also impairs the body's ability to form necessary clots to repair everyday wear and tear, particularly in the delicate lining of the stomach and the blood vessels in the brain. As we age, our tissues become more fragile and the risk of spontaneous bleeding naturally increases. Adding aspirin to the mix is like pouring gasoline on a smoldering fire. So, the question you should ask yourself, or rather your doctor, is, am I more like Eleanor, taking a medication with real risks for a benefit that, for me, may not even exist? For tens of millions of healthy seniors, the answer is now a clear yes, and the safest course of action is to avoid starting aspirin in the first place. Now, it is absolutely critical that we discuss the other side of this coin. While the new guidelines are very clear about who should not start aspirin, they are equally clear about who should continue taking it. This is the group of patients for whom aspirin is being used for secondary prevention. As we discussed, this means you are not trying to prevent a first event, you are trying to prevent a second or subsequent one. If you have already had a heart attack, if you have had a stroke caused by a blood clot, if you have had a stent placed in one of the arteries of your heart, or if you have undergone coronary artery bypass surgery, then you have established cardiovascular disease. For you, the conversation is entirely different. In these cases, low-dose aspirin is not just a recommendation, it is one of the cornerstones of your treatment. It is considered a life-saving medication. Why the stark difference? It comes down to a simple but profound shift in the risk versus benefit calculation. Once you have a history of cardiovascular disease, your personal risk of having another event is dramatically higher than that of the general population. The data shows that your risk of a second heart attack, for example, is many times greater than the risk of a first heart attack for someone like George or Eleanor. In your body, we know there is an underlying process of atherosclerosis, the buildup of plaque in the arteries, that has already proven itself capable of causing a major clot. For you, the blood-thinning effect of aspirin is not a speculative benefit. It is a proven therapy that actively works against the very disease process that is threatening your life. It helps prevent platelets from sticking to those unstable plaques and forming a new clot that could trigger another heart attack or stroke. I want to emphasize this with a patient story. I have a patient named Frank, a 68-year-old retired firefighter. 5 years ago, Frank had a heart attack. It was a wake-up call. He was rushed to the hospital, and the doctors performed an angioplasty, placing a small metal stent in his coronary artery to hold it open. He was discharged on a cocktail of medications, including a daily 81 mg aspirin. Frank is doing wonderfully now, but he told me that after hearing the news about the aspirin guidelines changing, he was tempted to stop taking it. "I feel great," he said, "and I hate taking pills." I explained to him in no uncertain terms that the stent in his heart is a foreign object, and the body's natural reaction is to form a clot around it. The aspirin is what helps prevent that from happening, keeping his artery open and the blood flowing freely to his heart muscle. For Frank, stopping aspirin would not be a safe choice, it would be a dangerous gamble. The benefit he gets from that simple, inexpensive pill, drastically reducing his risk of another heart attack or a clot forming on his stent, far, far outweighs the risk of bleeding. So, I need everyone watching to hear this loud and clear. If you are taking aspirin on the advice of your doctor, because you have a history of cardiovascular disease, please do not stop taking it on your own. Reading a headline or watching a video like this is for your education, not for self-treatment. Any decision to change or stop a critical medication like aspirin must be made in consultation with the healthcare provider who knows your specific medical history. Is your current reason for taking aspirin for primary or secondary prevention? This is the single most important question you need to be able to answer. Let's take a moment to put some more precise numbers to this risk versus benefit discussion, because sometimes seeing the data can make the concept much clearer. It's like balancing a scale. On one side, you have the potential benefit, preventing a heart attack or stroke. On the other side, you have the potential harm, causing a major bleed. For the scale to tip in favor of taking the medication, the benefit side must be significantly heavier than the harm side. As we saw in the Aspirin trial, for healthy seniors in their 70s, the two sides of the scale were nearly balanced, or worse, the harm side was heavier. The study reported that over about 5 years, 162 people in the aspirin group had a major bleeding event compared to only 102 in the placebo group. That's a 60-person difference, a statistically significant increase in harm without a corresponding decrease in heart attacks. The risk of bleeding isn't static, it increases as we age. A person's risk at age 65 is not the same as it is at 75 or 85. The lining of the stomach becomes thinner, and the small blood vessels in our brain become more brittle. Furthermore, many older adults are on other medications that can also increase bleeding risk, such as other blood thinners like warfarin or Eliquis, or even common over-the-counter pain relievers like ibuprofen or naproxen, which are known as NSAIDs. When you combine these drugs with aspirin, the risk of a GI bleed can multiply. So, for a 75-year-old with arthritis who takes ibuprofen regularly, adding aspirin for primary prevention creates a much higher bleeding risk than it would for a 60-year-old who takes no other medications. This is why a personalized assessment with your doctor is so critical. They can use risk calculators to estimate your 10-year risk of a heart attack and weigh that against your personal risk of bleeding, considering your age, other health conditions, and current medications. Now, let's look at the scale for someone in the secondary prevention group, like my patient Frank with the stent. His 10-year risk of having another heart attack could be 20% or even higher. For him, studies have shown that aspirin can reduce that risk by about 25%. That is a massive, life-saving benefit. It means that for every 100 people like Frank who take aspirin for several years, we can prevent a significant number of recurrent heart attacks, strokes, and deaths. In this scenario, his risk of having a major bleed, while still real, might be around 1 to 2% per year. When you weigh a 25% reduction in a catastrophic event against a 1 to 2% risk of a serious complication, the scale tips decisively in favor of taking the aspirin. The benefit side is far, far heavier. This is the simple math that guides our decisions. This is why we can confidently say aspirin is the right choice for secondary prevention, but the wrong choice for most healthy older adults for primary prevention. A question I often encourage my patients to think about is this: what does risk feel like to you? Are you more worried about the risk of a potential future heart attack or the risk of a medication-induced problem happening right now? Discussing this feeling with your doctor can help tailor a plan that aligns not just with the medical evidence, but also with your personal values and concerns. So, we've covered the science, the guidelines, and the patient stories. Now we come to the most important part. What should you do next? How do you take this information and turn it into concrete action to protect your health? The single most important step is to have an informed conversation with your doctor or primary health care provider. Do not make any changes to your medications on your own based on this video or anything else you read online. This information is meant to arm you with the right questions to ask, so you can be an active partner in your own health care. Let's break down the action steps based on your situation. First, if you are currently taking a daily aspirin and you have never had a heart attack, stroke, stent, or bypass surgery, meaning you're taking it for primary prevention, you need to schedule an appointment with your doctor. This is the group most affected by the new guidelines. When you see your doctor, here are 3 specific questions you should ask. 1. Given the new USPSTF guidelines, do I still need to be taking this aspirin for my heart? This question immediately frames the discussion around the most current medical evidence. 2. Could we assess my personal risk of bleeding? I'm concerned about the potential for a stomach bleed or a brain bleed. This shows you understand the specific risks and want to know how they apply to you, considering your age and any other medications you take. 3. If we decide to stop the aspirin, what are the most important things I should be doing instead to protect my heart? This is a crucial follow-up, shifting the focus to proactive, proven strategies. Now, for the second group, if you do have a history of heart disease, a prior heart attack, stroke, stent, or bypass, and you're taking aspirin, your action step is simpler. Keep taking your aspirin exactly as prescribed. However, it is still a good idea at your next regular checkup to confirm your treatment plan. You can ask, I just want to confirm that because of my history, daily aspirin is still the right and necessary treatment for me, correct? This provides reassurance and keeps the lines of communication open. Regardless of which group you fall into, this conversation about aspirin opens the door to a more important discussion about the true pillars of heart disease prevention. With the de-emphasis on aspirin for primary prevention, we are now rightfully placing even more focus on the strategies that have an overwhelming body of evidence supporting them. These are managing your ABCs. A is for aspirin, which we now know is for a select group. B is for blood pressure. Is your blood pressure consistently below 130/80? High blood pressure is a silent killer and the single biggest risk factor for stroke. C is for cholesterol. Do you know your LDL, or bad cholesterol number, and is it in a healthy range? High cholesterol directly leads to the plaque buildup that causes heart attacks. And S is for smoking. If you smoke, quitting is the single most powerful thing you can do for your heart. Beyond these, we focus on a heart-healthy diet, regular physical activity, and maintaining a healthy weight. These aren't just suggestions, they are powerful medicine. For many healthy seniors, successfully managing blood pressure and cholesterol will prevent far more heart attacks than a daily aspirin ever could, and with none of the bleeding risk. As we move the conversation beyond just aspirin, it's essential to truly appreciate the profound impact of these other pillars of primary prevention. For many years, taking a pill felt like an easy, passive way to protect ourselves. It was a simple box to check off each morning. But the new guidelines are, in a sense, a call to action. They ask us to shift our focus from a simple pill to a more engaged and holistic approach to our own wellness. This is an empowering shift. It means that the power to protect your heart lies not just in the pharmacy, but in your kitchen, your walking shoes, and your daily habits. Let's talk about what this really looks like in practice. When we talk about blood pressure control, it's not just about taking a medication if your numbers are high. It's about understanding what drives blood pressure. The number one culprit in the American diet is excess sodium. Are you aware of how much sodium is hiding in your food? It's not just the salt shaker on the table. It's in canned soups, processed meats, frozen dinners, and even bread. A practical step is to spend 1 week diligently reading the labels of everything you eat. You might be shocked. Aiming for less than 1/500 milligrams of sodium per day can have an effect as powerful as a prescription blood pressure pill for some people. Similarly, incorporating potassium-rich foods like bananas, sweet potatoes, and spinach can help your body naturally balance sodium levels and lower blood pressure. It's a simple dietary swap that can have a huge impact. Next, let's consider cholesterol management. While medications like statins are incredibly effective and necessary for many people, especially in secondary prevention, our diet plays a starring role. The focus here is on reducing saturated and trans fats, found in red meat, full-fat dairy, and commercially baked goods, and increasing soluble fiber and healthy fats. What does that look like on your plate? It could mean starting your day with a bowl of oatmeal, which is packed with soluble fiber that acts like a sponge to soak up cholesterol in your digestive system. It could mean swapping butter for avocado on your toast, or having salmon for dinner twice a week to get those heart-protective omega-3 fatty acids. These aren't drastic, miserable diets, they are small, sustainable upgrades to the food you already eat. Have you ever done a pantry audit to see where hidden sodium or unhealthy fats might be lurking? Could you try swapping one red meat meal for a fish or bean-based meal this week? Finally, we cannot overstate the power of movement. You do not need to run a marathon. The goal is consistency. Aiming for 150 minutes of moderate intensity activity per week is the gold standard. That breaks down to just over 20 minutes a day. This could be a brisk walk around the neighborhood, a water aerobics class, dancing to your favorite music in the living room, or gardening. The key is to find something you enjoy, because that's what you'll stick with. Regular activity helps control blood pressure, manage weight, improve cholesterol levels, and reduce stress. It is truly the most powerful, multi-purpose medicine we have, with only positive side effects. This shift away from routine aspirin for prevention is a wonderful opportunity to reinvest in these foundational habits that benefit not only your heart, but your entire body and mind. So, let's bring everything together. We've navigated some complex medical information today, and I want to recap the most important take-home messages for you. The landscape of heart attack and stroke prevention for seniors has fundamentally changed, and it has changed for the better, moving toward a safer, more personalized approach. The single most important concept to remember is the difference between primary and secondary prevention. First, for primary prevention, meaning you are over 60 and have never had a heart attack, stroke, stent, or bypass surgery, the routine use of daily aspirin is no longer recommended. The evidence, particularly from the large Aspirin trial, is now clear. For this group, the risk of serious bleeding caused by aspirin outweighs any potential benefit in preventing a first cardiovascular event. If you fall into this category and are currently taking aspirin, this is not a cause for panic, but it is a clear signal to have a conversation with your doctor about whether it is safe and appropriate for you to stop. Second, for secondary prevention, meaning you do have a history of heart disease, a stent, or a past stroke, aspirin remains a critical, often life-saving medication. For you, the benefit of preventing another catastrophic event is well established and far outweighs the bleeding risk. Please do not stop taking your aspirin unless you are specifically instructed to do so by your cardiologist or primary physician. The ultimate message today is one of empowerment. Knowledge is power, and you are now equipped with the most up-to-date information to be an active participant in your own health care. Medicine is not a one-size-fits-all discipline, especially as we get older. Your health history, your lifestyle, your values, and your other medical conditions all play a role in what the right path is for you. Use this knowledge to ask better questions and to work with your doctor to create a prevention plan that is tailored specifically to you, one that likely emphasizes the proven pillars of health: managing your blood pressure, controlling your cholesterol, and embracing a healthy, active lifestyle. Thank you for spending this time with me today. I know this is a topic that carries a lot of weight, and my hope is that this discussion has brought you clarity and confidence rather than fear. Your health is your most valuable asset, and taking charge of it is the best investment you can ever make. If you found this information helpful, I encourage you to subscribe to the channel for more trustworthy, senior-focused medical advice. And please share this video with friends, family, or anyone you think might be confused about this important issue. You could be helping someone have a crucial conversation with their doctor that could protect their health for years to come.